Okay, so this lecture will focus on blood flow restriction training. Okay, so the topics that we'll cover are the effectiveness of BFR, and I want to not so much go into the detail of each of the studies, but I want to expose you to the breadth of the patient demographics that BFR has been studied with. We'll look at the limitations of the BFR in clinical practice and the future implications, and we'll have a discussion at the end. Okay. Okay, we'll look at a meta-analysis, control limb comparisons, and post-operative. So this study was presented in the pre-class lecture. So Jeremy Leneke, the effect size when you're looking at cross-sectional area for low-intensity BFR versus low-intensity resistance training, superior effects on the when you're looking at the effect size, moderate to large. When you look at muscle strength, even more so superior. Again, 0.5 or larger effect size when you're looking at the coefficient of R is large. I thought this was a good study that looked at females. Though they were healthy, the significance of the study is that the individual the individual was allocated to two different groups. So one lower extremity was allocated to BFR or no BFR. The BFR leg utilized 25% versus 50% 1RM. It was only done for 4 weeks. They did 3 sets to failure with a standardized tempo. The outcomes were the isokinetic dynamometer, looking at 1RM, isometric max volitional contraction, and torques. Okay, so within a 4-week time frame, on the limb that was trained with BFR, they showed that there was a 26% increase in their 1RM, which is rather significant within a 4-week time frame, both of which are statistically significantly different than their opposite limb. Same thing when you look at their isometric or max volitional contraction in Newton meters or torque, 106% increase in 4 weeks. Most interesting and really profound for me was the amount of blood flow that was changed within the limb. So changes in blood flow over the 4 weeks, where there was a significant increase statistically, not only from pre and post, but definitely compared to one limb compared to the next. You're looking at milliliters per minute per 100 milliliters of blood flow. Okay, let's talk about muscle preservation. I think this is one of the key roles that BFR may play in postoperative status. And so they took a group of 15 males. They were healthy otherwise, and they put them in the isometric group, control group, or no exercise BFR group. So the BFR group, as it specifies, did no exercise. The isometric group did exercises 2 times a day for 2 weeks. The BFR group, their regimen was 25 times 5 minutes with 3 minutes rest 2 times a day. They simply occluded their limbs. All subjects immobilized their left ankle, cast, and crutches for 2 weeks. Isometric grip. The isometric group, knee extension and flexion and ankle planar flexion. Volume and intensity. So BFR, you can see the intensity there, and then you can see the volume that the isometric group did, 1 times 20 times 5 second contractions. So when you look at the data after the 2 weeks, you can see that the circumference muscle loss is on the y-axis, and you have the different locations on the limb that were measured. And what you're looking at is that the control as well as the isometric group lost muscle mass throughout the limb compared to the BFR group, despite the BFR group doing no exercise at all. When you look at the actual strength and the function of these individuals, is that the the BFR group statistically significant in all metrics as far as their strength when you're looking at, regardless of the speed at which you're looking at their plantar flexion torque. The reason why you're seeing negatives here is because obviously they all went under some form of detraining, but the effects were actually, like the loss in strength was significantly less in the BFR group. Okay, knee extensor strength, same story as the plantar flexion torque. Knee flexor strength, same bit. So this is a sub-study that looked at the effectiveness of BFR post ACL. So 16 individuals, 8 in the BFR group, 8 in the control, males and females, average age 23. They did it for 2 weeks, from the first day post-op, or 3 days post-op to 14 days post-op. They did not do any exercise. They simply occluded one group, and the other group, the control, put on the cuff but didn't inflate it. We can expect post-ACL that an individual will lose between 20 and 30% of their quad girth. And when you look at the statistics, again, you have the experimental group on the left, the control group on the right. You can see the extensors. As far as the experimental group, they only lost approximately 9.5% of their quadricep, whereas the control group, as expected, lost 22% of their quad mass. So again, just the presence of occluding one's blood at a regimen of twice a day for 25 minutes can preserve their muscle mass significantly post-ACL. And if you're doing the math, the significance here is that the control group lost an additional 120% of their quad mass relative to the. Okay, so we had previously considered aerobic exercise with the pre-class. You'll remember that Sleaze et al. In 2016, regardless of whether you look at strength or hypertrophy in aerobic training studies, when you pool the data, that they both favor low intensity. One study that did catch my eye was this study in particular, where they did 19 healthy controls for 8 weeks, 24 sessions. Everybody cycled at 40% VO2 max. However, the BFR group only did so for 15-minute sessions, where the control group did 3 times as much exercise. They did so for 45 minutes per session. That equated to the control group doing 12 hours more of exercise. The results look like this. So you have a change in cross-sectional area on the thigh and quadricep. So again, favoring the BFR group in red. And when you look at their change in cross-sectional area again, or I'm sorry, cross-sectional volume done with MRI. What was most interesting as well is that the BFR group, though they did, again, a 20 hours less of cycling, they had a 6% increase in their VO2 max. And again, they were cycling at a very slow, a very small percentage, relative smaller percentage of their VO2 max. Whereas the other group, same intensity, did 20 hours more of exercise, no change. Same with their exercise time to fatigue. BFR group increased by 15%. Additional groups that we want to consider are population. So a meta-analysis and systematic review was conducted just this year. So you had 2,600 subjects, 11 included. But when you actually look at the data, that the low intensity, or the low load versus low load BFR significantly increases their strength pre and post. And you can see that that's given in percentile. And then the effect size is large to very large at 0.86. When perhaps you don't do resistance training with these individuals, and perhaps you just have them walk on a treadmill with BFR, and you can expect that there will still be strength and hypertrophy gains, and that's 13.3% increase in strength, as well as muscle growth versus the muscle loss if they're just walking on the treadmill. A very large effect size here at 3.0. Okay, if you're looking at muscle mass, again, the large effect size of 1. Okay, the conclusion was the addition of low-load BFR resistance training or walking is an effective exercise alternative for older adults for whom traditional high-load training may be contraindicated due to the comorbidities of high mechanical stress to bones and joints. Okay, let's consider the neurological population. So this is one area in which BFR is just in its infancy, but there's promising early. So this is a case report on an individual with Parkinson's disease. It was a 10 weeks crossover design study. So the first phase, first 6 weeks, they did BFR. The last 4 phase, they did nothing. They continued the training, but they did no occlusion. You can see that the individual's hemodynamics are shown there from 1 week to the next with no significant changes during the exercises. And there's actually a drop in the peak weekly blood pressure. So the exercise was simply walking on a treadmill with BFR. So looking at the timed up and go, you can see the effects of the crossover design. So there's a preservation of about 2 weeks where BFR, the BFR results remain. So from week 0 to 6, as indicated on both of those for the timed up and go and sit to stand. Obviously, for timed up and go, you want a lower score is better, and for the sit to stand, the number of repetitions is also better. So 2 weeks preservation, and then a drop off after the BFR was removed. So 6-minute walk and rest, and this is RLS or restless leg syndrome scale. You can see that consistently that the crossover design and the effectiveness of BFR was lost. But you can see the improvement that was made with BFR. Okay. Additionally, there's been studies that look at have looked at an fMRI of individuals who are utilizing BFR. So this was an inaugural study done in BYU. BFR cohorts completed less work and achieved a similar amount of brain neural activity as with a higher volume of exercise. So brain neural activity, the conclusion was brain neural activation is important overall patient health, and these findings may be important for prescribing training with BFR in clinical and applied research settings. Additionally, there's positive effects on bone. So early indications are when you look at the data of the studies that have been conducted. This was a systematic review in 2018. That aerobic training combined with BFR increases the BAP, which is a biomarker for positive bone remodeling. Low intensity training combined with BFR decreased bone metabolism during an acute bout. Showed significant ALP concentrations and bone ALP. Again, a biomarker for positive bone metabolism. Regardless of which study you look at, they all show promise. Okay, so let's talk about the BFR. So there's 5 of them that I've come up with. One, it's important to note that BFR results are not superior to heavy load resistance training. The second, the use of non-FDA regulated cuffs, poor prescription practices of clinicians who are administering BFR. Effects of chronic BFR utilization is unknown, just because it's only recently come into the States, as I mentioned in the pre-class presentation in 2008. And then the methodology of study design, when you look at some of the systematic reviews, they denote areas of the increased risk of bias, and then also the fact that there's a lot of there's several products that have come out with BFR cuffs, that there may be conflicts of interest during the research because of. So here's an example of the first limitation where meta-analysis compared high intensity resistance training to BFR. And you can see that for muscle strength adaptations, and hypertrophy, the consistently higher loads wins out in the long term. Okay, BFR cuff selection. So you can see that there's a whole host of different cuffs that have been implemented onto the market. None of them are FDA approved. So there's only two that have been FDA approved, and that is the Owens Recovery Science and the Smart Cuffs, or also put out by Smart Tools. So I had a discussion with one of the clinicians in my previous clinic that I was working with, where they were using a B Strong cuff, which is also common. It's actually also used in the Division I training room here at Stanford. And I was inquired whether it was necessary that the cuff be FDA regulated, and that perhaps the clinic should consider one of the other FDA regulated cuffs. And the owner that I had a discussion with didn't think that it was necessary. In fact, I contacted B Strong's CEO directly, and he also reassured me that these were not regulated by the FDA, and that it wasn't otherwise indicated that they be regulated at this time. It's just, and he gave the example of your stationary cycle. So there's no FDA regulation on a stationary cycle, but you see it across across the nation in the clinical setting. So that caused me to then reach out to the FDA representative specifically, and what they specifically said was that if there was a product that was already FDA regulated, which there is, Owens Recovery was the first, then any other product that is said to do the same result of that FDA regulated product also needs to be registered or mandated. If that wasn't enough justification that such companies such as B Strong need to actually be registered, then the next thing is that the FDA states that that anything that is indicated for medical use or a medical product is required by federal law to be regulated by the FDA. And so I strongly recommend, or I guess I don't recommend anything, I'm just giving you the limitations, but this is one of the limitations, is that non-FDA regulated cuffs are being utilized setting. Okay, when we look at poor prescription, so based off a survey that was done last year by Patterson et al. In 2018, where they surveyed 250 strength coaches, sports scientists, physiotherapists, researchers, and doctors, people who were in rehabilitation or strength and conditioning field, that only 11.5% of them actually based the pressures that they were using off the specific limb occlusion pressure, which is what is recommended in the guidelines in the positional stance that you read. Literature, other respondents, majority of them used the literature values regardless of their patient pressure, the patient's hemodynamic. Then you look at limb circumference, Patient brachial blood pressure was also utilized, which there's been shown to be no correlation between that and their lower extremity and being able to predict their lower extremity limb occlusion pressure. Then when you look at Katsu training, so in Japan, you can see that one area of concern here is this was a survey of over 12,000 subjects, and there's occlusion timelines here that certainly exceed the safety recommendations. So anywhere between 20 and 50 minutes is excessive. There should be an intermittent or interset deflation rate or deflation period here. So again, further cause for concern when poor prescription is applied. Okay, and then the final two limitations, effect of chronic BFR utilization is unknown, again, because it's only recently come into light. And then the methodology of the study design, risk of bias and conflicts. Okay. Low intensity BFR increases muscle size and strength. Quantifiable muscle adaptations present quickly. Training greater than 6 weeks offer greater returns. BFR training has applicability to a range of populations who may seek to progress strength while reducing loads on the associative tissues, including muscles, tendons, connective tissue, and bone. Early studies indicate that BFR may have positive effects on bone remodeling. There are 5 limitations. High load resistance training is superior. The types of cuff that are used, the prescriptions, etc. All right, so let's talk about the future implications points. So future applications and demographics. BFR is rapidly expanding. I presented this material in the pre-class lecture. So you can, future implications are looking at lower extremity postoperative, upper extremity postoperative, general when you're looking at knee arthroplasty, nerve injuries. There's research being done in myositis, astronauts, geriatrics, adolescents, and neurological populations. There's even evidence to suggest that there's potential cognitive improvements with the BFR and being an effective, and BFR being an. Okay, so let's talk about the discussion points. What initial questions do you have regarding the information that is presented here? Do you see value of BFR in the clinical population that you treat? Early studies have shown positive outcomes with total joint rehabilitation with home administration. We're considering the longevity of joint preservation. Musculoskeletal injury leads to decline in quality of life and immobility, which leads to cardiovascular and systemic morbidity, which eventually can lead to mortality. So I'm a physically active individual, and I like going to the gym, and consistently I see, and I've even been known to really test my body's physical abilities with a lot of load, with back squat, deadlifts, benching, push-ups, etc. If I want to maximize my health and longevity of my body and preserve the most limiting factor, which I believe is my joint health, then perhaps BFR would be a way that we can continue to really physically and mentally tax ourselves like we enjoy, at least I enjoy at the gym, while doing so for an entirety, for a longer time period without really putting too much harm on the joints. What concerns do you have about BFR? Thank you for listening. Bring your questions, comments, concerns, feedback. Happy to discuss. Okay, these are my references. Feel free to flip through them.